organizing this webinar. And this webinar is a monthly webinar and fourth in the series. And as I shared, today we are blessed to have Dr. Mala Srivastava and Dr. Kanika Jain, who would be helping us decipher and understand a bit more about how to manage breast health in our day-to-day clinical practice. And Dr. Kanika Jain will help us understand the management of the rising polycystic ovarian syndrome condition. So this is a brief profile of Madam Professor Dr. Mala Srivastava. She is the head of Gynec Oncology Unit and a senior consultant and professor at Ganga Ram Institute and Medical Education Research. She's also the president of Nachi Delhi chapter 2024-2026. She has achieved several awards to her credit, especially the Foxy Achiever Award, the APJ Abdul Kalam Excellence Award, and she holds multiple roles in the past as well as currently holding multiple roles. And again, to share, we are literally blessed to have her in this forum. And with this, I'll request Madam to share her slides and go ahead with her sharing on her topic of breast health management. Ma'am, over to you.
Thanks, sir, for your kind introduction. And it's my pleasure and privilege to be with you all this evening. I'm going to speak today evening on the saga of the breast, what a gynecologist must know. So, gynecologists are a primary physician. We, the gynecologist and the obstetrician, our patient comes to us during pregnancy or for other antenatal checkups as well as for delivery. So if they have any problem with their breast, they come to a gynecologist as a primary physician because they think that their primary physician as an obstetrician and gynecologist, we can address the breast problems as well. So breast inspection starts looking for any asymmetric findings, which include abnormalities in the overall breast shape, changes in skin color, skin dimpling, retraction, spontaneous nipple discharge. There can be lump. There can be change in skin color or texture, change in how the nipple looks like, pulling in of the nipple, or clear or bloody fluid that leaks out of the nipple. There can be asymmetric findings also. So when there is a commonly encountered breast concerns in outpatient, there can be mastalgia, palpable breast masses, nipple discharge. This can cause significant patient anxiety about development of breast cancer. However, most clinical breast changes in women are benign. Only 3 to 6% of cases are due to breast cancer. Thus, as a primary physician, all obstetrician and gynecologists must know how to identify these conditions. Identification of benign breast disease could be the most important contribution a gynecologist can make during routine examination. So what is mastalgia or mastodynia? It is a pain related to the mammary gland occurring either spontaneously or on touch. 60 to 70% of women experience some degree of breast pain at some stages of their lives. 10 to 20% of cases, it can be very severe. It consists of two types. Either it can be cyclical mastalgia or non-cyclical mastalgia. Cyclical and non-cyclical, we have to know the difference between the two. Regarding cyclical mastalgia, breast pain occurs 1 to 2 weeks prior to menses. Pain is diffuse and bilateral with some radiation to the upper arm and axilla. Can be more severe in one breast than the other, relieved by the onset of menstrual flow, and there is less chance of being cancer. Regarding non-cyclical mastalgia, pain is usually unilateral and localized to a particular quadrant of the breast, can resolve without treatment in up to 50% of cases, but can also be more difficult to treat. Various causes of non-cyclical mastalgia include cyst, periductal mastitis, stretching of Cooper's ligament. Rare but occasionally can be associated with malignancy. So what is the etiology of mastalgia? Exact etiology remains undefined. Cyclic breast pain related to hormonal changes. Increase in estrogen levels stimulates breast elements of the ductal elements of the breast. Simultaneously, there is a decrease in progesterone and there is stimulation of stroma. So there is concurrent increase in prolactin, causing increased ductal secretion, which also contributes towards pain and swelling. Mostly resolves after hormonal events such as pregnancy or menopause. Non-cyclical mastalgia, less common related to hormonal variation, and it's more likely to be due to anatomical cause. So we have to evaluate the mastalgia in a stepwise manner. If a woman presents with breast pain, you have to take the history and the physical examination. History regarding pain profile, location, quality, severity, laterality, temporal relation to menses, medication history, musculoskeletal triggers, impact on daily function, and family history of breast cancer. All these are important when we are trying to take the history and the physical examination. If there is no palpable pain, there are two possibilities. It is a cyclical pain, then imaging is not indicated. If it is a non-cyclical pain, then you have to see whether it's a focal pain or diffuse pain. If it is focal pain, less than 30 years, you have to do ultrasound. More than 30 years, you have to do either ultrasound or diagnostic mammography, or you can do tomography as well. That is digital breast tomosynthesis. If the patient is non-cyclical as well as diffuse, age is less than 40 years, then imaging is not indicated unless risk factors for breast cancer. Age more than 40 years, diagnostic mammography, or you can do digital breast tomos. If there is a palpable mass, age less than 30 years, ultrasound. 30 to 39 years, either diagnostic mammography, digital breast tomosynthesis, or ultrasound. More than 40 years, definitely mammography. So what is the treatment of cyclical mastalgia? You have to reassure the patient that most of the time the cyclical mastalgia do occur due to hormonal changes during the cycle, and there may not be any underlying cause. You just give lifestyle changes, that is low fat diet, active lifestyle, use of well-fitting bra. They can all improve the symptom relief. NSAIDs are effective in management of mild symptoms of mastalgia. Side effects are stomach problems, nausea, vomiting, and drowsiness. If the breast pain is severe and refractory, the additional hormone therapies can be considered. It should be only used for short periods because of its side effects. We can give tamoxifen, danazol, bromocriptine, or gozeril. Tamoxifen is preferred hormonal treatment, relieves cyclical mastalgia in 70 to 90% of cases. But side effect is causes irregular menses and hot flushes. Danazol, only drug FDA approved for treatment of mastalgia. Side effects, weight gain, deepening of voice, menorrhagia, and muscle cramp. Bromocriptine stimulates the dopaminergic receptors and blocks the release of prolactin. Side effects have severe side effects, the commonest being nausea, vomiting, and dizziness. Goserelin reserved for treatment of severe refractory mastalgia. Side effect, vaginal dryness, hot flashes, decreased libido, and irritability. So treatment options available for management of mastalgia, which comes with significant side effects. If there's palpable breast mass or lump, then what you do? Breast cancer diagnosed only in 10% of new breast lumps. Essential to have an approach to investigating breast lumps that is simple to follow. Limiting over-investigation, preventing the misdiagnosis of malignant breast lesions. Evaluation of breast masses with very few exceptions. Every patient who presents with a breast lump needs to undergo triple assessment. Risk of breast cancer increases with age. A full triple assessment of every patient, regardless of age, increases in the cost at no benefit to the patient. Hence, age of the patient can guide investigators in the workup of the breast lump. So what do you mean by triple assessment? History and physical examination, breast imaging, and biopsy. If the age is less than 19, common causes are fibroadenoma, hematomas, fat necrosis, and abscess. So what do you do? Clinical examination. Red flags, irregular firm mass, skin erythema or tethering, spontaneous bloody discharge through the nipple, new onset nipple retraction, and rapidly enlarging mass. More than 20 and less than 24, commonest causes fibroadenoma, inflammatory breast conditions, and hematomas. Clinical examination is and ultrasound is fair enough. More than 25, fibroadenomas, inflammatory breast conditions, cyst, and breast cancer. Clinical examination, ultrasound, mammography if older than 40 years, and may need biopsy. So how do you take the history for breast lumps? Socrates and acronyms is a useful to explore the characteristics of the patient's breast. Site, ask about the location. Onset, when the breast lump appeared. Character, specific characteristics. Radiation, if the pain is associated with breast lump, ask if it radiates. Associated symptoms, ask if there are other symptoms which are associated with breast lump. Time, clarify how the breast lump has changed over time. Exacerbating or relieving factors. Ask if anything appears to have triggered the onset of a breast lump. Severity. Assess the severity of associated pain by asking the patient to grade it on a scale of 0 to 10. So how do you do the physical examination? Palpation. First of all, you do the inspection, then palpation. So when palpating, pay attention to the shape. Benign lesion, very regular borders. Cancerous lesion, irregular in shape. Consistency, benign lesions are rubbery or elastic consistency, probably malignant rock hard or otherwise very firm. Relation to skin, very fixed to skin, usually malignant. Changes over time, rapid changes over a week to months, chances of cancer is there. Tenderness, benign, more the chances of being tender, cancerous, non-tender. A mass that changes in tenderness during menstrual cycling is most likely to be benign. So how do you palpate? Ask the patient to indicate the exact location of any masses felt during self-examination. How do you do the examination? Either in circles or in wedges or in lines. So management of breast mass. If there is a breast mass, do physical examination, sonography, and fine needle aspiration. Of course, before the physical examination comes the history take. And that we have taken to the acronym Socrates. Women less than 35 years, no or yes, compatible with fibroadenoma, no or yes. If it is compatible, no, you just excise. Yes, follow up every 6 months until the age of 35. No change, then you can go and excise. Enlarges, excise. Regression, follow up until complete regression. For women more than 35 years, compatible with fibroadenoma, no, then excise. Yes, follow up for 6 to 12 months. Enlarges, excise. Complete regression, routine follow up. Follow up, if there is incomplete regression, again excise. So fibroadenoma and fibrocystic breast disease, they're the two most common benign tumor conditions. In different studies, they have found that among benign breast disease, fibroadenoma has ranged between 30, 72, 38, 40, and 77% in different studies. Whereas fibrocystic disease has ranged from 11, 27, 32, and 4.3 in different studies. Meeting में So a painless unilateral benign breast tumor that is solid, not fluid. How do you see? Mama ka phone. Most common lump across all age groups. 95% of breast lumps in adolescent are fibroadenomas. 10% of world's female population suffers from fibroadenoma once in a lifetime and peak onset between 15 to 35 years of age. So how do you evaluate? How do you evaluate the cases of fibroadenomas? Most commonly occurs in the upper and outer quadrant of the breast. Asymptomatic fibroadenomas are often discovered as incident findings during screening mammography. So what are the features in physical examination? Non-tender or painless, mobile, solitary, rapidly growing solid lump with rubbery consistency and regular borders. Mammography will show well circumscribed mass with or without popcorn-like calcification. So management of fibroadenoma, initial management of fibroadenoma, first confirmed by imaging studies. You have to do careful management, observation, follow-up. Fine needle aspiration or core needle biopsy may present iatrogenic risk in the developing breast. Cryoablation can occur in adults, but we have never tried and we have never seen. Surgical excision if the mass is symptomatic and rapidly growing. What about fibrocystic breast disease? Thickening of the breast tissue and fluid-filled cyst in one or both breasts is characterized by fibrocystic breast disease. Extremely common, 90% women during their lives, not associated with increased risk of malignancy. However, associated with approximately 50% risk of developing breast cancer under certain histological and clinical circumstances. A palpable mass upon clinical evaluation is evident in both benign and malignant breast condition. The findings include symptoms such as dimpling of the skin, thickening of breast tissue, breast pain, and nipple discharge. So how do you manage? For patients presenting with mastalgia, you have to do lifestyle changes, supportive bra, altering the dose of hormone replacement therapy regimen. Analgesics like aspirin and ibuprofen are options. Use of evening primrose oil is warranted as supportive measure if pain persists despite treatment and advice. 3 to 6 month period is the suggested time frame to observe the desired effect. If the breast pain is severe, more than 6 months, and disrupts daily activity, you can give tamoxifen, bromocriptine, danazol. Cysts that repeatedly, despite frequent FNA, have an intracystic solid appearance on ultrasound or have atypical cells present upon cytopathological evaluation, then you have to consider surgery. So what about nipple discharge? It is the third most common breast-related complaint. 80% of women have an episode of nipple discharge during reproductive years. 80 to 90% of patients with nipple discharge has benign condition. So how do you evaluate? There is a nipple discharge. The character of nipple discharge, color, whether it is bloody, spontaneous or provoked by stimulation, single or multiple ducts discharge. If it is, you think it is physiological, there can be systemic cause, that is excessive hormone secretion, either elevated TSH or prolactin levels. You have to do medical management. Physiological, less than 40 years, observation, more than 40 years, mammography, if needed, screening mammography. Pathological, mammography and or ultrasound, abnormal biopsy, negative findings, breast MRI or surgical excision. So management of nipple discharge. Physiological, non-spontaneous, multiple duct or color is white or milky or green. Routine screening, imaging and examination. Pathological, spontaneous, bloody or serous and single duct discharge. Negative mammography or subareolar ultrasound. Counsel of low risk of carcinoma less than 3%. Major subareolar duct excision with preoperative ductogram to guide excision. And 6 months follow-up, imaging and exams until resolved for 1 or 2 years. If there's abnormal mammography, you have to do image-guided percutaneous biopsy or image-guided subareolar major duct excision. Role and efficacy of evening primrose oil in management of mastalgia and benign breast condition. So we want to introduce what do you mean by evening primrose oil? Evening primrose oil is extract from a plant and is omega fatty rich oil. Women with breast pain are known to have low concentration of GLA and metabolites. Evening primrose oil is a rich source of linolenic and gamma linolenic acids, 74% and 14% respectively. It also has a good efficacy and safety profile with mild side effects. So, role of evening primrose oil, mastalgia and breast lumps. Evening primrose oil restores saturated and unsaturated fatty acid balance, decreases sensitivity of breast tissues to circulating hormones, increases levels of PGE1, which has an anti-inflammatory action, attenuates sensitivity of breast tissue to prolactin, decreases conversion of arachidonic acid to pro-inflammatory leukotrienes. So this is the role of evening primrose oil. So what does the textbook says about evening primrose oil? According to Shaw's textbook of gynecology, evening primrose oil diverts harmful PGE2 to PGE1 and replenishes CNS PGE1. It thus suppresses irritability and depression, as well as reduces fluid retention and mastalgia. According to Mansell and Webster's benign diseases, disorders and diseases of the breast, owing to EPO's moderate efficacy and good safety profile, it is recommended as the first-line treatment option for the management of mastalgia. According to Essentials of Breast Surgery, since treatment with EPO shows a higher response rate, significant improvement in pain, and minimal adverse events, it is recommended as a first-line treatment for cyclical mastalgia. So, how effective is evening primrose oil in vitamin E for cyclical mastalgia, a prospective study? You can see reduction in the worst pain after 6 months of treatment from the baseline. EPO plus vitamin E, that was -4. EPO alone -3.5. Vitamin E alone -2.9. Placebo -2.6. So EPO, that is 1 gram BID, plus vitamin E showed superior efficacy compared to individual treatments and placebo in alleviating breast pain associated with cyclical mastalgia. This chart also shows that 90% patients reported complete resolution with only EPO and vitamin E as first-line treatment. You can see 90% patients. So clinical factors affecting the therapeutic efficacy of evening primrose oil in mastalgia. Study design was retrospective case control study. Study included 1,015 patients with mastalgia. Determined the effectiveness of EPO and factors affecting its efficacy in treatment of mastalgia. Outcome was significant reduction in VAS score observed with EPO at week 6. EPO can be reduced in the treatment of mastalgia without significant side effects. EPO for the treatment of breast lumps, and what is the clinical evidence? For fibroadenoma placebo-controlled trial, women with benign breast lumps were given EPO 4 gram per day for 6 months in 21 patients. There was reduction in size was observed in 52% of patients receiving EPO within 6 months. Regarding cyst, it was a double-blind randomized controlled trial. Women with breast cysts received either EPO 6 capsules daily or placebo for 1 year. 1,200 patients were enrolled. Recurrent cyst formation in the first year was lower in the EPO group compared to the placebo group. EPO was also well tolerated. So to summarize, the importance of breast complaints and disorders lies in their history, incidence, discrimination between benign and malignant disease. A large overlap between the symptoms. Breast cancer is not the only disease entity of breast. Given incidence of mortality rate of breast cancer, breast screening must be part of the primary care of all women attending a gynecological clinic. In fact, in our practice, We do opportunistic screening for all the women who are coming above the age of 40 with any complaints to our clinic. We offer them 3D mammography or tomography to them. Evening primrose oil is an effective and safe management option for mastalgia, and it helps reduce lump size in fibroadenoma and fibrocystic breast disease. Thank you for your patient listening.
Thanks a lot, ma'am, for your short and sweet sharing on the breast health management. Ma'am, just was wondering, you mentioned about use of nutraceuticals as well as pharmacological agents. Can I check like medications like tamoxifen, danazol, bromocriptine, goserelin? How common are they used in the clinical practice?
Normally, we don't use these drugs.
Okay.
The time we get desired effect with evening primrose oil and vitamin E.
Okay.
We have rarely used these drugs.
Okay. So basically, nutraceutical, that is evening primrose oil, is your preferred choice.
And lifestyle modification, diet alteration, it does help.
And what is the dosage which you find more effective in your setting of evening
We
primrose oil?
give 1 gram twice daily.
1 gram twice daily. And usually, how good is
3
the
months.
compliance? How good is the compliance, and how long do these?
Yeah, compliance is good because the patient, if they are really disturbed with their breast pain, and they do follow the regime very sincerely, and they do come back and say that they are feeling much better.
Sure, ma'am. And because these females would be looking for immediate relief, so how do you counsel them that nutraceuticals do take some time to produce that?
Tell them that of course, we tell them, you see, you are a living person, you're a dynamic. Human body is a dynamic thing. It's not a static. That you put switch on, the light will be on. You put switch off, the light will be off. So it's a dynamic process. It is not a static process. Even the medicines, they take some time to act on the body tissues. And the body takes some time to react. That is how we counsel our patient, that you will get the effect maybe in 10 days or maybe 2 weeks, but then you have to be on with the treatment. You have to comply with the lifestyle changes. Then you have to also comply with the diet and exercise. Everything combined will give you the desired effect. We are not giving you any magic pill.
Sure, ma'am. And when it comes to the benign breast condition, this was about mastalgia, but for fibroadenoma and fibrocystic, would you still prefer evening primrose oil, or there are what is your choice?
Some patients may benefit with talking about fibroadenoma. We have to counsel them depending on the size of the fibroadenoma, whether because it may require surgical management. If the lumps are more than 2 centimeters and depend on the age of the patient and desire of the family, whether they want to go ahead with the surgery or not, we can counsel them. It's a benign condition, but after all, it's a tumor. Tumor is going to increase in size as the time passes. Today it is 2 centimeters. Maybe after 2 years it becomes 4 centimeters. So it's always better to nip the evil in bed. But so that is the thing. So the sooner the call for surgery is taken, even for fibroadenoma, that's good enough.
Sure.
That's how we counsel. It's not an emergency operation. That's not a cancer. So you have to take a call immediately. But you can plan your surgery maybe after 10 days or 1 month or 2 months. But you have to keep in mind that fibroadenoma is a tumor. It needs surgical intervention. And the sooner it is done, the better it is. And at your planned time.
Sure. And till the surgery happens, do you manage medically these patients?
Yeah,
Or
we
do you
can
manage
give them symptomatic treatment. We do give them some evening primrose oil and vitamin E, because that also gives patient satisfaction that she has something to do while she's waiting for the surgery.
Sure. So would the dosage be the same, 1 gram twice daily? Because clinical trials hired.
There's no point in giving suboptimal dose.
Sure.
If they're treating medically, they have to treat fully, completely. There's nothing, there's no role of half-hearted.
Sure. And can I also check when you do use nutras for your patients, nutraceutical like evening primrose oil, do your patients are keen for a nutraceutical, or often they question why a nutraceutical and why not a pharmacological drug?
See, we have to say that our diet is not very composite diet or comprehensive diet. It does not contain everything that it should, and it's not practical. Also, sometimes that you do not take the nutrition value of each the food item that you are taking. We try to give them a concept of balanced diet, that the Indian thali that we talk about, but most of the women Indian women cannot take it.
Sure.
And it's not even very practical every day to have that Indian comprehensive balanced diet. Maybe sometimes they are very aware. They some for 10 days or maybe 15 days they will take it, and then again they go back to their normal routine, whatever they were taking. And maybe there are many other problems, social problems, financial problems, everything, and awareness and easy cooking and all that goes hand in hand. So it's very difficult to make your patient stick to the balanced diet that we talk about, or maybe the Indian diet, because maybe special situations like a pregnancy or in the post-operative period, for some time they will stick to it. And then they will again go back to their routine habits. So we try to tell them that by nutritional supplements, we are trying to bridge the gap of nutrition in their body. And this gap can be easily done, maybe very faster with the drugs that we are giving. And maybe you'll feel much better earlier. Then wait for the balanced nutritional diet to take it over.
Sure, madam. I think that was really nice and interesting and good pearls of wisdom. Ma'am, with your due permission, can we move ahead to the next talk by Madam Dr. Kanika Jain, ma'am, if it's that's okay?
Yeah,
Yeah.
go
So I
ahead.
give a brief profile of Madam Kanika Jain, and then we'll go ahead with her session. Dr. Kanika Jain again is a senior consultant. Just a minute, let me take a pointer so that it becomes easier. So she is a senior consultant gynecologist, endoscopic and robotic surgeon. She's part of the minimal invasive gynecologic unit at Sri Gangaram Hospital, New Delhi. So we are literally blessed to have two eminent speakers from our capital of the country, that is New Delhi. She is also the secretary of Nachi Delhi. She has held multiple positions in the national committees across India. She's also an examiner for DNB exam. So anyone trying to appear for DNB, I think would be good to connect with her. She is, as I shared, she's also into writing and publication. So she's a co-editor of AOGD from 2008 and 9. So anyone looking for publishing, ma'am would be the right person to take some advice from. With this brief intro, I'll pass on the platform to madam for her sharing the slides and going ahead. Ma'am, over to you.
Thank you, Dr. Manish. Am I audible?
Yes, ma'am, you are loud and clear.
Okay. So let me share my slide. First of all, I thank Dr. Manish and the nutraceutical group to include me in the program. So is my slide visible?
Visible, ma'am. Quite clear and laser pointer also visible.
Okay, thank you so much. So a very good evening to all. And let me just minimize this so that I can be able to see. Okay. So after such an elaborate and nice talk and discussion with Dr. Mala, I hope I don't bore the people. My talk would be on empowering PCOS management. Basically the natural way, the natural, effective and a safe solution for that. So PCOS, as we all know, is these days the prevalence has really gone up. Almost 25% of the population is suffering from PCOS, and my not moving. Okay. So it is a very common endocrinological problem, and basically what we can say is it is a lifestyle disease. It's not a disease as such, it's a lifestyle problem these days. And it is very commonly affecting the reproductive age group women. It's a metabolic disorder with a common endocrine pathology. So it impacts the women across the lifespan from adolescence to the postmenopause. And in Indian women, the prevalence is increasing. It's on the rise and it's almost 11%. The etiology is complex, involving genetic and lifestyle factors. Clinical presentation is also varied with reproductive, metabolic, and psychological features. So, what is the pathophysiology of PCOS? If we see in PCOS, we mainly find there is insulin resistance, there is hyperandrogenism, there are hormonal derangements. These are the major underlying pathophysiology of PCOS. And as we say, as I commonly tell my patients, the imbalances in between the hormones, the male hormones, they become dominant over the female hormones, as is the tendency of the males to dominate the females. So this is the same tendency, the hormones start dominating, and as a result, the female hormones are suppressed. The female hormones are required for ovulation, and that is how the cycle of menstruation goes on. So if that dominance disrupts this cycle and the follicles, they start maturing, but in between, somewhere in the middle path, they are stopped. So they do not mature further, and as a result, there is not the ovulation does not occur. And these suboptimally grown follicles, they start collecting in the periphery of the ovary, giving it a pearl string appearance on ultrasound. So it is called polycystic. As such, this should be a misnomer. These are not cysts, because many a times patients come to us saying that they've got cysts in the ovary. They are not cysts. They are all unruptured and non-mature follicles, I would say, because they are trapped in the middle of the path of maturation. So the cycle goes as in there is androgen excess, leading on to hirsutism, acne, insulin resistance, then increased androgens, and then there is perturbed ovulation, as I said. With it's a vicious cycle, and there is basically no progesterone surge, and GnRH is not controlled. So the GnRH, the normal pulse, as shown here, but what we get is an increased pulse frequency of the high GnRH. So the LH, the luteinizing hormone secreting cells, they secrete more of LH, which stimulates the androgens, and increased synthesis is there from the theca cells, again leading on to androgen excess, and this cycle goes on. So what are the signs and symptoms associated with PCOS? We see that the PCOS girls or females, they have irregular periods. As a result of irregular periods and ovulatory cycles or dysovulatory cycles, there is difficulty to conceive. There are increased levels of luteinizing hormone. The FSH goes down and the LH becomes preponderant. There is acanthosis, which is like darkening of the skin. There is increased acne again, and a hyperandrogenism, effect of hyperandrogenism. There is decreased FSH, as I said. There is increased hirsutism. Because there are more male hormones, so obviously the lady would have more of beard and mustaches and hirsutism over the face, and there is balding of the scalp, as goes with the male hormones. Then there are enlarged ovaries with polycystic appearance. There is weight gain. There is difficulty in losing weight also. There is, because of the weight gain in these cases is very resistant. So it is very difficult to lose weight. Then the lady will have all sorts of mood changes, menstrual and pelvic pains, dysmenorrhea is severe. Periods are irregular and delayed, and then when they come, they are very heavy and very painful. So if left untreated and unresolved, it can lead to various complications, such as metabolic dysfunction, which is seen in 47% of cases. There is 1.7 times increased risk of coronary vascular disease or cardiovascular disease. There is 70 to 80% patients who develop infertility. So we have to have a holistic management of PCOS by addressing the underlying pathophysiology of PCOS. This should be the priority, which can help in correction of the PCOS features and prevent or reduce the risk of PCOS associated complications. So here we have berberine. So berberine is a natural product which can be used in PCOS management. So what is it? It is basically a type of isoquinoline derivative alkaloid which is found in various herbs of the Berberis species like Berberis vulgaris, Berberis aristate, etc. And in Ayurveda, this is known as Daru Haridra. Now, the history of berberine from past to present, it has a long history of medical use dating back to the very ancient times. The fruit of the berberry plant, which contains berberine, was used for its blood purifying properties as early as 650 BC. It was first isolated and characterized by Buchner and Herberger in 1830. After extensive research over the years, it has emerged as a natural remedy for various ailments, including digestive, cardiovascular, neurological, metabolic, and endocrine diseases. Nowadays, it has gained popularity as a potential treatment option for PCOS in the Western countries. So, berberine is a multi-target, multi-path plant extract which is used in the treatment of PCOS. It activates the AMPK pathway, leading on to translocation of glucose transport protein type 4, which channels into the cell membrane and increases the glucose transport into the cells. So there is increased glucose metabolism. There is it increases the insulin receptor expression. So the insulin resistance that normally is seen with PCOS patients, that decreases, and it improves the insulin sensitivity and promotes the glucose utilization by the cells in the body. And it suppresses the androgen receptor signaling. So the androgen receptor binding is inhibited, which ultimately leads on to hyperandrogenemia and reduces the insulin resistance. So a clinical study on the short-term effect of berberine in comparison to metformin on the metabolic characteristics of women with PCOS was done. And this study was done in China, and they found that the treatment with berberine in comparison to metformin showed a decrease in the waist circumference, in the waist to hip ratio, in the total cholesterol, in the triglycerides, in the LDL, as well as an increase in the HDL lipoprotein, which is the good cholesterol, you can say, and the sex hormone binding globulin. Similarly, treatment with berberine in comparison to placebo for insulin resistance showed that there is an increase in the HDL and cholesterol, that is, and the sex hormone binding globulin. So it showed berberine, in a nutshell, they found showed similar effects as compared to metformin in insulin resistance, hyperandrogenemia, and the body weight. So now we're talking of a product which is not a pharmacological medicine. It is a natural product. So if we get similar results with berberine and metformin, then we definitely can go on to natural things. Now, there was another study, this is an Indian study, on the effect of berberine, mya-inositol, and metformin in women with PCOS. This was a prospective randomized controlled trial, which concluded that berberine may have greater potential to reduce the risk of cardiovascular disease than metformin in PCOS patients due to its effect on the body composition, lipid profile, and improvement in the hormonal status. And they saw that berberine showed a similar improvement as compared to metformin after 3 months of treatment in terms of insulin resistance, blood sugar levels, hyperandrogenemia, body composition parameters, and the lipid parameters. And berberine was associated with a similar improvement in various outcomes as compared to metformin. So now, this was another study which showed that the effect of berberin phytosome on reproductive, dermatological, and metabolic characteristics in women with PCOS. This was a controlled, randomized, multicentric, open-label clinical trial, and the study confirmed that the positive effects of berberin supplementation in women with PCOS with high safety profile of this nutraceutical. So it had the result. This study uh, pregnancy.
हाँ?
Hello.
Yeah, ma'am, you are audible.
Your voice is breaking, Kanika.
हाँ तुम्हारा
Voice break हो रही थी.
Ma'am, just check your audio. You're closer to your audio.
मैं
Ma'am, you want to switch off your video so that the Wi-Fi is proper. आपका audio break हो रहा है.
Hello.
Dr. Kanika, ma'am, you want to switch off your videos so that the audio comes properly.
Hello.
Yeah, ma'am, now we can hear you.
So they said that and we have to monitor the liver function and my liver function cannot form the pressure. And this was another study effect of gluten on reduction. Yes, this is systematic and open. They found that during a patients this and decrease and temperature. The
Dr. Kanika, ma'am, there's some problem in the audio. Priya, you facing that same challenge? Dr. Mala, ma'am, are you able to hear the audio well?
No, I am not able to hear the audio well. I think आपको वो करना पड़ेगा, Dr. Kanika.
हाँ
वीडियो
मैं
ऑफ
ना
करना
ये
पड़ेगा.
ऑफ करती हूँ हाँ
हम्म.
मैंने बीच में हटाया था
अभी साफ आ रही है आवाज. Now, we can't hear you.
Then just disconnect the Bluetooth from your laptop. Ma'am, full screen and then your audio, please. Hello, madam, you there? Mala madam, can you hear her voice or something?
Still not audible, Dr. Kanika.
She's just logging in. So, ma'am, by the time she logs in, let me just check with you on how common is the mild, moderate, and severe variant of this breast pain? Do patients come only when they have severe pain, or do they also come when they have a mild and moderate pain, breast pain?
So basically, they come when the pain is troubling them in their day-to-day life. So they do come with at least moderate pain.
Okay. And basically, then the moderate pain, obviously, you mentioned about the management and the algorithm which was there. So that's pretty clear. Ma'am, you mentioned about fibroadenoma. If they are more than 2 centimeter, then you go with the surgical part. But if they are, say, 1 centimeter or lesser or a diffuse variant, would your
If they're
treatment?
less than 2 centimeters, then we can observe them for some time because they are slow-growing tumors. They may or may not grow. If it is a 1 centimeter fibroadenoma, it may take 2 to 4 years, maybe 5 years to become 2 centimeters. So they are slow growing tumors. They may not grow as fast that they will require surgery in near future. So depending on their age, marital status, their social background and everything, we can keep them under observation.
Sure, ma'am. And can I also check like breast health and the self-examination? It's so simple and easy, but how common and how practically is it adopted by most of the females to do the self-examination? Is it common
See,
or there's still
basically,
lack of
if
awareness?
they fall into the high risk category, that if they have a family history of breast cancer, then they are very sensitive. They do follow breast self-examination, clinical examination. They do follow the protocols of coming to the doctor every year after the age of 35, getting the examination or ultrasound done. I think Dr. Kanika has joined,
Yeah, okay, join. Ma'am, you
but
want to
if they
share
do
your,
not
yeah,
belong to that high risk category,
yeah.
then the compliance may not be very good. So
Ma'am, please go ahead and
awareness
share your slides,
is
Kanika ma'am.
important. Yeah.
Thanks a lot, Dr. Mala ma'am.
पता नहीं क्या problem है. Am I audible now?
Ma'am, there are thoda audio ke paas closer if you can be so that your voice is
Yeah,
clear.
you are audible.
Yeah, ma'am,
Kanika.
audible, yeah.
Okay. I'll try to be loud. So, the slide is not moving. Okay, so this was another study which was published in the Obsgyne journal. The PCOS management, a review of the possible amazing role of berberine. And the results showed that it is safe, effective, and a promising molecule in the management of PCOS. This was another one which showed berberine phospholipid is an effective insulin sensitizer and improves the metabolic and hormonal disorders in women with PCOS. A one group pre-test, post-test explanatory study. And this also showed that berberine represents a safe, novel dietary supplement, which is helpful in the treatment strategy for PCOS. Now, the safety profile. We have seen all the positive, we've analyzed all the positive effects of berberine as compared to metformin. Now, we must know the adverse effects also for us to be able to assess a proper safety profile. So the adverse effects reported are mild, transient, and occasional. There is anorexia or loss of appetite. There can be abdominal pain, nausea, vomiting, diarrhea, constipation, and increased flatulence. Better safety profile is seen as compared to metformin because there is lower incidence of GI side effects like nausea, vomiting, diarrhea, and abdominal pain. And no adverse effect has been reported till now that berberine lowers the vitamin B12 levels. So it is a better tolerated, well tolerated, and a favorable safety profile drug. So in a nutshell, berberine is a nutraceutical supplement to manage PCOS with fewer or minor side effects. What are the effects? It reduces the insulin resistance, it reduces the inflammation, it promotes the weight loss, it improves the abdominal lipid levels, it improves the hormonal derangements, and it reduces the androgen levels. So it has a multi-target effect seen on PCOS. Now the use of myoinositol and D-chiro-inositol, which normally are in the ratio of 40:1. So this in PCOS management. So what is myoinositol and what is D-chiro-inositol? These inositols are present in all living beings and they participate in many metabolic pathways. There are two forms of myoinositols. Inositols primarily they derive from the dietary sources of myoinositol. MI can be then converted to DCI by an enzyme epimerase under the stimulus of insulin. So under the physiological conditions, the MI-DCI ratio averages 100:1 in the follicular fluid, which is required for a good ovulation, and 40:1 in the plasma. The ovarian balance between these two forms supports the normal hormonal secretion and the ovarian function. Now, what is their role at the ovarian level? At the ovaries, we see that FSH stimulates the granular cells to secrete estrogen, to convert the androgens into estrogen under the effect of aromatase enzyme. And MI promotes this, and DCI inhibits the aromatase. So as a result, the conversion of androgen to estrogen is hampered. In LH, which acts on the theca cells, cholesterol is converted to androgens, and this is promoted by the D-chiro-inositol. These androgens then go to the granular cells and are converted into estrogens by under the effect of MI by FSH. So MI increases the FSH activity, and DCI, it acts as an aromatase inhibitor and participates in the androgen production. So what is the effect of these two in glucose metabolism? MI and DCI normally work in synergy in the glucose metabolism. MI increases the glucose uptake in the cells, promotes the conversion of glucose to glycogen as a storage form. And DCI, it promotes the glycogen synthesis, but it increases the breakdown of glucose. And it also increases the insulin release. So what happens to the ratio of MI by DCI in PCOS? Hyperinsulinemia forces the epimerase to convert MI to DCI. So the ovary becomes rich in DCI. DCI has an inhibitory effect on the aromatase, leading on to the increase in the testosterone levels, the male hormone levels, and a concomitant reduction of estrogens. So MI deficiency causes a negative effect on the FSH signal and on oocyte quality. So the best combination to manage PCOS would be 40:1 MI to DCI. So why supplementation with MI is to DCI and 40:1 ratio is the best combination to manage these PCOS? In PCOS, we see that MI and DCI ratios impaired in the ovary. Thus, the various MI is to DCI ratios are tested, and several studies concluded that a combination of myoinositol and D-chiro-inositol in the ratio of 40:1, which is what we see in blood, the physiological ratio, seems to be the best choice to restore the endocrinological impairments. That is significant reduction of LH, pre-testosterone, fasting insulin, and the HOMA index, which indicates the insulin resistance, and an increase in the estrogen level in overweight or obese PCOS women. Further studies have revealed that the PCOS treatment with MI DCI on the ratio 40:1 has allowed the ovaries to return to their histological characteristics, improves the LDL, HDL, and triglyceride levels, reduces the fasting and circulating insulin levels, and improves the oocyte quality. Now, what are the advantages of adding other nutraceutical supplements in PCOS management? So we've seen the effects of berberine, we've seen the effects of myoinositol and D-chiro-inositol. Now, what are the other nutraceutical supplements which can help in PCOS management? So one is CoQ10, the role in PCOS. So the mitochondrial dysfunction and oxidative stress, they have been implicated in the pathogenesis of PCOS. So the CoQ10, it protects the ovary from the oxidative damage. And clinical data implies that addition of CoQ10 is a safe therapy to improve PCOS by improving the insulin resistance, increasing the FSH and reducing the testosterone, and improving the blood lipids. Now, the role of vitamin D in PCOS. We see that 67 to 85% of PCOS patients, they have concomitant vitamin D deficiency. The deficiency leading on to low bone mineral densitometry, risk of osteoporosis and fractures, obesity, insulin resistance, hirsutism, hyperandrogenism, elevated risk of coronary cardiovascular disease, and ovulatory dysfunction and menstrual irregularities. So supplementation of vitamin D causes improved bone health, improved menstrual regularity, improve the lipid profile, improve the insulin resistance, reduce BMI, and reduce cardiovascular risk. Now, the role of methyl folate in PCOS. There is significant elevation of homocysteine levels, which is seen in PCOS women with insulin resistance, with androgen excess on metformin P. So, ultimately leading on to increased CVD risk. Methyl folate supplementing reduces the homocysteine levels, leading on to the reversion of these effects. Now, chromium role in PCOS. Chromium is an essential element in the metabolism of glucose, insulin, and lipids. Its supplementation in PCOS has shown to be beneficial in terms of decreased BMI, decreased fasting insulin, and decreased free testosterone. So this was about the nutraceuticals in the management of PCOS. Thank you.
Ma'am, thanks a lot for your pulse of wisdom again for the polycystic PCOS condition. Can I check with you, like, what is the earliest age where a PCOS can be diagnosed or the polycystic ovarian condition can be suspected?
Well, with the if you see with the pediatric endocrinologist, girls as early as 8 or 9 are having Minaki. So the early telltale signs of acanthosis and raised BMI and such things are cropping up even as early as 7 to 8 years of age. So that is the age, that is the tender age when these things are showing subtle signs and symptoms, and they should be picked up. It's
Sure.
because of the lifestyle changes, because of the diet, that dietary changes that have been brought about in our society, with the junk food and the fast food being the major component.
Sure. So apart from lifestyle and diet management, does the treatment options differ depending on the age of the patient?
Definitely, treatment options would differ, but the nutraceuticals, as pointed out, they are all nutritional supplements which are lacking in our diet. So they can be given in any age group. But otherwise, as far as the pharmacological drugs are concerned, yes, the treatment varies with the age. Reproductive age girls want to conceive, so their treatment varies. Perimenopausal ladies, they are more concerned about the risk of cardiovascular disease, dyslipidemia, hypertension, and all those metabolic disorders that crop up. Early teenagers are more worried about the acanthosis, the hirsutism, acne, so they have to be treated accordingly.
Sure, ma'am. And on an average, when a PCOS female comes to you, how good is the compliance to treatment, and what is the average duration of treatment for which they continue the treatment apart from diet and lifestyle? And do they stop taking in between? Then how do you encourage them to restart? Just a thought on the cycle duration
See,
of treatment.
basically, I think all such patients need time. They cannot be just told that you do some lifestyle changes, you do exercise, you lose weight, and do some dietary changes, and you'll be fine. They are never satisfied. They need some prescription of some drug, and drugs we don't want to write. So nutraceuticals give us that option that we are prescribing them something. They feel that they are taking some medicine, and as a result, they show improvement also. So as far as compliance is concerned, again, it varies. They do window shopping. Such patients, they do not recover completely. the hirsutism worsens, the child doesn't stop eating junk food, there is no discipline, lifestyle is not good. So they feel the doctor is at loss, the doctor is at fault. So they keep changing. But the intelligent patients, I have patients who have been with me, they started with their teenage, and the girl is now 33. So it's a long duration, and she follows, and she strictly follows instructions also. And I've hardly ever given her metformin or any other drug, maybe for withdrawal sometimes. So it is
So,
the counseling that matters.
yeah. So is it right to say that polycystic ovarian syndrome, which you mentioned, can begin right at the age of menarche, 8 years, 9 years, and can go until what age max in the life of a woman? Is there any cutoff age? Or
Well, with PCO, with menopause,
yeah,
obviously there is a little stoppage of this, but then post menopause, as it is, the testosterone levels rise. So the hirsutism never goes, it rather comes back. And the cardiovascular risk, the hypertension, diabetes, all those problems they crop up. So it's a lifestyle disease, lasts almost lifelong.
and does your treatment approach, apart from diet and lifestyle, differ based on the predominant symptoms of a PCOS patient? If it's
Definitely.
more
If
androgenic,
somebody
and
comes
how do
for
you choose
acne,
different treatment options?
if somebody comes for acne, if somebody comes for hirsutism, if somebody comes for infertility, so obviously the treatment would differ.
Sure. Just want to, if it's okay with you, just wanted to get some perspective from Dr. Srivastava, madam, also. Ma'am, your views and thoughts on PCOS and how do you manage in your clinical practice?
See, basically, PCOS is a quite a common condition nowadays, and I think there's a lot of awareness also among the adolescent girls as well as young girls regarding PCOS, because they are aware of their acne problems, acanthosis, their weight. They are aware of these things, but they, of course, their lifestyle is something to worry about, because it's very difficult for them to encourage them to go for exercises as well as to modify their diet. And these are the most difficult lifestyle changes that we have to push. Medicines definitely come later on. First of all is the awareness, desire to follow instructions, and then alter their diet, lifestyle, and it's very difficult to ask them to inculcate exercises in their lifestyle, in their routine. They'll have lots and lots of reasons not to go for exercises. They will have exams, they will have studies, they will have their career, they will have some other commitment. That is how they go on. Still, we try to counsel at each and every visit. If they follow the instructions, they follow the diet, they follow the exercises regime, they do improve a lot. And if they find results, they comply, they stick to it. But if they do not find the results in short time, they move on from doctor to doctor and do doctor shopping, as Dr. Kanika also mentioned.
Sure, ma'am. Thanks for those insights. Ma'am, Kanika, ma'am, if I can check with you, is there any possibility of change in the name of PCOS condition, or is there any work going on in changing globally this name, or it will continue as a PCOS condition only? Because you mentioned there are multiple dimensions to this condition,
It,
including metabolic.
it was earlier named polycystic ovarian disease. In the very old days, the treatment used to be wedge resection, and then that used to be an open surgery. Then with laparoscopy, ovarian drilling started to get the ovaries into ovulation, to get the cycles normal. So then it was named polycystic ovarian syndrome, and now all those things are obsolete. They are considered obsolete. It was earlier called the Steen-Leventhal syndrome after the scientists who discovered it. So I am not too aware of any further change of name, but yes, it has been, people have been starting to call it as a metabolic disease, a lifestyle problem.
Sure. And just one last query, if I can ask, lean and obese PCOS, does your
30%
treatment
of the, yeah, 30% of the patients with PCOS are lean and thin. So they are rather more difficult to treat. because there is no absolute change in BMI or such parameters that we can say. So for them, dietary restriction is definitely what we advise, but we cannot tell them that you reduce weight and that will improve the situation. They're already lean. And sometimes with these patients, we see that the AMH levels are very high. And but it is because of the insulin resistance, it is a very resistant variety of high AMH. The ovulation still is not.
Sure. Dr. Srivastava, ma'am, any add-on views from you in addition to what ma'am shared? Lean and obese, your approach to manage, and any specific nutras you would prefer in either of the two, or you would prefer the nutras in both the conditions? Ma'am, you're on mute.
Basically, when we talk about lean PCOS, they still require medication and lifestyle modification, because we still have to guide them regarding good nutrition. Because lean doesn't mean that they are perfect in nutrition. So they have to be guided regarding correct and balanced nutrition, and sometimes support has to be given with the nutraceuticals.
Sure, ma'am. I think that was great. And thanks, ma'am. I'll just, Priya, you are there for the closing remarks?
Yes, sir, I am very much there. So, thank you so much, Dr. Kanika Jain and Dr. Mala Srivastava. A wonderful presentation, I must say, very enlightening and very, very informative. And another thing I really appreciated was the Q&A session. Dr. Manish Garg has really asked such important, crucial questions. And Dr. Jain and Dr. Srivastava really answered them so well. So thank you so much for this wonderful coordination, interaction. I have learned myself so much. So just to introduce myself, I am Priya. I am the group product manager, and I'm handling these brands, Primosa initiatives, regularly once in a month with collaboration with AMOGS. I thanks a lot, Dr. Kanika Jain and Dr. Srivastava, to remove your precious time and to be our speakers. I thank Dr. Manish Garg for again removing his precious time in spite of his hectic schedule. He has really made this webinar so wonderful by his presence and intellectual discussions. I thank the entire field force of women healthcare team, because they have really gone out of the way to promote these webinars and ensure that it is hugely successful. I have been keeping a track of number of attendees. Doctors who have really attended today's webinar is about 143 as of now. So the credit goes to all of you as well as our field force. I thank all our technical staff for all the technical everything that they have organized this team. And that's all. Thank you so much. It was wonderful having you. And any help, support you need from us, please let me know, ma'am.
Thanks a lot, Priya.
Yeah.
Thanks a lot. Thanks a lot, Srivastava, madam. Thanks a lot, Jen, ma'am. Thanks a lot. Looking forward for more future coverage. Thank you, ma'am. Thank you, ma'am.
Thanks and goodbye.
Goodbye. Goodbye, ma'am. Goodbye, sir.
Thanks a lot. Aman, can you disconnect the transmission? Thanks a lot, ma'am.
Recording stopped.